screen, if it goes to 100, the logical thing is that, okay, Charishma, we can start. Hello. Charishma.
Good morning, everyone. I'm Dr. S. Cherishmanjali, IDCCM resident from Care Hospital, Bedside. My moderator is Dr. T. Lakshmi Rani ma'am, a critical care HOD from Care Hospital, Bedside. Today, I'm going to discuss about communication in ICU. Today, I'm going to discuss about the definition of communication, communication techniques used, how to communicate with healthcare professionals, communication with the patients, communication with family, and the various communication skills, training, teaching, and analysis. Coming to the definition of communication, communication can be defined as the mutual exchange of information between two or more individuals. It is an integral and fundamental aspect of our social system and an accepted part of our daily life. It is very effective and important part as it serves as a means to re-establish our communication skills with the patient. In ICUs, effective communication becomes important as it serves as a means of re-establishing social contact and receiving and giving information. It is a two-way dynamic, continuous transfer of information and requires inputs from all the members of the staff, family, and patients. Communication with professional colleagues, patients, and their relatives is a very fundamental skill that is very important and necessary in intensive care medicine and is central to good medical practice. Relatively, very little curriculum time is allotted to communication skills development, as the emphasis is being placed mainly on acquiring medical knowledge and acquiring clinical competence. Medical journals previously rarely referred to the subject of communication skills and development, although recently multiple articles have begun to appear more frequently. Who all come under healthcare professionals? All the people that are in contact with the patient are coming under the term healthcare professionals. They include doctors, mid-level providers, nurses, patient navigators, pharmacists, technologists and technicians, therapists, and rehabilitation specialists. What are the various types of communication? The types of communication include verbal communication, non-verbal communication, written communication, and visual communication. What are the various problems we encounter in ICU? The problems we encounter in ICU are mainly due to patient factors, family factors, and the clinician factors. Coming to the patient and family factors, communication usually becomes difficult due to anxiety associated with the unfamiliar surroundings and the severity of the disease and their reaction to the prognosis of the disease. They become surrounded by unfamiliar people and there is loss of touch with the familiar faces, and the noisy equipment also in the ICU also increases the anxiety levels of the patient. Hence, it becomes difficult to communicate with the patient and family. Altered mental status of the patient also affects communication. It usually occurs due to administration of sedative drugs, or the disease process itself can hinder the patient's mental status. Any presence of barriers to verbal communication due to presence of endotracheal tube also hinders the communication with the patient. Coming to the clinician factors, communication becomes difficult as the doctors become busy with many patients and emergency procedures, due to which they can spare minimal or less time with the patient and families to communicate with them. What are the various communication techniques used? We have crisis communication, interprofessional discussion, communicating with patients, and family meetings. Family meetings are further subdivided into initial consultations, clinical updates, and end-of-life issues. Crisis communication. Critical care is a teamwork. It cannot be done by a single person. Hence, good communication is necessary to function as a successful team and to be a good leader. To become a good leader, we should inculcate qualities like to achieve which include the ability to establish a shared mental model, the ability to coordinate tasks, and to centralize the flow of information. The leader should be able to come to a common ground. They have to coordinate tasks, like who is going to do which task is to be completed by which team member, and to establish a structure, and to stabilize the emotions in during an emergency or conducting a task. Or to have a efficient patient care team, the leader should have good leadership qualities. They should be able to monitor the situation, and they should receive mutual support from other members of the team and have good communication with the team members. All this together improve the performance, attitude, and knowledge of the team, and helps in completing an emergency or a task successfully. Interprofessional communication. Communication among healthcare professionals is usually needed during ICU rounds. It occurs between staff and doctors and during handovers, and to communicate with referral doctors while coming to an agreement on the treatment of the patient, and while informing in the event of patients, we have to communicate with family or the referral doctor or the family doctor, coroner, or the police department in relation to any medical legal issues. We have to ensure good interprofessional communication. The healthcare professionals should work as a team and to avoid conflict among themselves. Thus, it can ensure good workplace environment for effective patient care. There are multiple methods to communicate among healthcare professionals. They include S-bar method. S-bar method is usually followed by nursing staff during their daily handovers. This can also be applied to clinicians for daily handovers. S-bar stands for S stands for situation, B stands for background, A for assessment, and R for recommendation. Situation, like what is going on with the patient. Background is what is the context. Assessment stands for what do you think the problem is. Recommendation, like what you do to correct the problem. For example, a situation like if we have an emergency situation, the situation becomes we have to introduce ourselves and tell them that I wish to sign over a patient to them. And background will be the history of the patient. Like if suppose a patient with history of trauma is admitted, and I want to give the history regarding this patient. Assessment is for stabilizing the patient, and what is the treatment given to the patient. Like any patient is surgically fixed, but he has a fever, so it could be probably due to infection. So what is the recommendation? The recommendation comes as the treatment we provide, which is suggesting to send some laboratory values or culture and sensitivity, or the patient is sick, to shift him to ICU. Next method of communication is 5-step advocacy. It is a method used to communicate in case of emergencies like code blue or medcall. It can be used by all healthcare professional team for attending emergency situation. There are 5 steps. Step 1 is seeking attention. State concern, state the problem, obtain a solution, obtain an agreement. Seeking attention. For example, if we have to seek an attention, we can say by, excuse me, doctor, state the concern. Like if the patient is hypotensive or any dyspnea is present, then that is our concern which we are seeking attention of the doctor. State the problem. So the problem will be, I think I need help here. That is the problem. Obtaining a solution. Solution could be either resuscitating the patient or what is causing the hypotension, or arranging for ICU transfer. Obtaining an agreement. Once we are obtaining a solution, we have to inform them regarding that I think this is, I want to do transfer him to the ICU, I have to resuscitate him or anything. And we have to double check with them whether they are on agreement with us. Does that sound good? Next method of communication is graded assertiveness. It is a communication technique that can allow anyone to challenge any action or behavior that they think is inappropriate. There are some certain steps like command. Command is instead of hesitating, we have to give the command that do this now. If suppose the patient becomes unconscious in case of code blue situation, instead of hesitating, like if whether we have to check the pulse or not, we have to give the command to the team that do this now, check the pulse now. Statement is we need to do the following. One, we have to, the statement could be we have to initiate CPR. Shared a suggested suggestion. It could be we have to take help from other team members and allot functions to the tasks to the team members, and all together should be doing the following. Query: what do you think we should do? Suppose even after 10 minutes of CPR or resuscitation, the patient is not able to be revived. We have to stop and think what is the problem, or what we should do further. What is the cause? Preference. Other team members could tell the leader that I think it would be wise to follow the following suggestion. Hint: if suppose things are going wrong, or if we think someone is doing something wrong, instead of directly telling them, we can give a hint. I think this is not the correct. I think we should things look like this, or maybe we are missing something. Other methods of communication include closed loop communication. This is a very important method of communication during a crisis situation, where the team finds out whether the command given is followed and inform back to the team leader. For example, if the leader gives a command like give adrenaline, it means that the team member who is administering adrenaline should administer the drug and also inform after administration of the drug so that the loop is complete. Flying by voice. It is a method used during crisis communication among the team members. In this method, the command or order given is voiced out to the team to prevent any mishap. So instead of thinking in our mind, we have to voice out what all tasks we are doing so that any mishap can be prevented. For example, if if the team leader says, team leader thinks that I have to give 1 milligram of epinephrine. Instead of thinking, he has to tell it so that inform one team member to administer the drug so that the method is carried out and there is minimizing the delay in the completion of the emergency task. And it also helps in ruling out contraindication. If the patient is contraindicated to some drug, and if someone thinks that we have to administer the drug and administers it, other team members, after listening to that, could help in telling that the patient is hypersensitive to it or contraindicated. And while telling during administration of the drug also helps in double checking and preventing any mishap. How to communicate with family and patients. There are 10 strategies for improved communication. We have to identify ourselves. We have to be honest and tell the truth. Be simple, dress appropriately, make time, instill confidence, admit uncertainty about prognostic predictions, work as a team, accept lack of trust, and employ educational tools. While communicating with patients, we have to assess the patient's ability and status. Before choosing the type of communication tools, we have to assess the patient's status and his ability to communicate with us. This can be assessed by checking the level of awareness to surroundings, his cognitive function, whether he is coherent, he is able to understand us or not, and level of sedation, like at what level of sedation he is, or whether he is deeply sedated or not, or on any assisted ventilatory devices like endotracheal tubes or tracheostomy tubes or any non-invasive masks. His level of auditory, visual, and language skills also should be assessed. His muscle power for functional ability to be assessed. It includes fine motor skill assessment and gross motor skill assessment. After assessing the functional skills, if the fine motor skills are intact, we can find out whether the patient can write. If the patient can write, we can provide pen and paper and communicate with him. If the fine motor skills are not intact, check for gross motor skills. And if the gross motor skills are intact, we can give a computerized AAC with switch or eye blink control. If the patient fine motor skills are intact but cannot write, we can provide communication charts or communicated computerized AACs. If the functional skills are not intact but motor skill abilities are intact, we have to check for a patient having tracheostomy. If the patient is tracheostomized, we can provide use a one-way speaking valve or speaking tracheostomy tube or electrolarynx to communicate with him. If the patient has a oral tube, we can use an electrolarynx. Nonverbal communication. Nonverbal communication includes facial languages, facial expressions, body language, and written communication. It includes mouthing, gesticulating, nodding, writing, lip reading, head gestures, facial expression, and writing on notepads. These are certain assisted devices for communication by non-speaking patients. They include communication board or charts, specialized talking tracheostomy tubes, electrolarynx in tracheostomized patients, high-tech augmentative and alternative communication devices. Patient communication boards. Certain ICUs have implemented the use of these charts to communicate and understand patients who could not verbalize. In these charts, there are diagrams where we can communicate with the patient by giving him a pen and asking him to point out what is he trying to communicate with us. This method is very useful and very simple and can be helpful in ICU communication with the patients. Staff rounds. Staff rounds are very effective in reducing patient anxiety and help better understanding of their illness. There was a study conducted by Lehman Ellis et al. About the effect of bedside case presentation on the patient's perception of the medical care. It was found that compared to bedside case presentation, they compared the bedside case presentation with conference room presentation and found that patients responded favorably to bedside presentations than conference room presentations. Bedside open discussions will assure the patient that his problem is receiving full attention and involve a team of doctors than a single doctor. Discussion away from the patients will increase patients' anxiety levels and they misinterpret that his situation is too hopeless to be discussed in front of him and they might lose trust in them. Try to avoid criticizing other doctors while holding rounds at the bedside. So finally, coming to how not to conduct a bedside round. Demonstration of lack of competence or disagreeing on treatment option with colleagues, criticizing colleagues, being pessimistic or raising the patient's anxiety. So to conduct an effective bedside round, we have to be competent and knowledgeable in our medical skills and be able to answer the questions posed by the patient and family. Never disagree on treatment options with our colleagues in front of the patient. Don't criticize the colleagues in front of the patient as it might lose his trust in us and also in our colleagues. Be optimistic. Try to relieve the patient anxiety and make them feel comfortable. Role of family in communication. Family acts as a spiritual, emotional, and physical support to patient. They act as a conduit between patient and the healthcare workers. They provide information from the healthcare workers to the patients, and they also provide information about the patient to the healthcare workers. They also support patients' facilities. Communication with family. Family refers to patients' loved ones, legal guardians, healthcare proxies, caregivers, next of kin, civil partners, friends of patient that have empowered to participate in their care. These family meetings have been identified as a strategy to prevent miscommunication, and it also helps in addressing the emotional distress caused by the intensive care environment. The patient's clinical condition is updated to the family by the medical team. Family liaison services. This initiative was started during COVID pandemic. It helped in ensuring timely and effective communication with the family members. The team usually is non-medical and helps in notifying the patient family about the patient's condition, his ICU admission, and it also addresses immediate concerns regarding the prognosis or the treatment going on. and it clarifies the details of the next of kin. It also informs early updates, and also it also informs about the visitation time and the visitation process, and it provides details about the unit treating them. The study conducted by Gabby et al., which is a study, the development of family liaison team to improve communication between intensive care unit patients and their families during COVID-19 pandemic, showed that the introduction of these family liaison teams has shown to reduce pressure on medical professionals and improve levels of satisfaction for patients' family members. The goal setting conference while meeting the family members. They were 10 step, it is a 10-step guide, and it helps in guiding us like what we have to follow, the do's and don'ts before meeting and during meeting the family and patients. It includes the guidance, what we have to follow before the meeting and during the meeting. We have to establish proper setting, introduction, assessing patient and family's understanding, review medical reviews and summaries. We have to be silent or understand the reactions of the patients, discuss prognosis, assess patient or family goals, present broad care options, translate goals into care plan, document and discuss. And we have to manage conflict. Before the meeting, before meeting the family or patient, we have to review patient's chart to know his medical conditions, his history, prognosis, and treatment options, what all treatment is going on, and what additional treatment can be provided, and coordinate with the medical opinions offered by other consultant physician and come to a common ground before meeting the patient or family. Decide which tests or treatments are medically appropriate. Review in advance care planning documents. Review or obtain patient's psychological and social information. We can know the family dynamics with the patient and his social economic status, and any conflicts are there between the family and patient. Decide who you want to be present from the medical team, and try to clarify your goals for the meeting, like what are the decisions we are hoping for the family to make and what are the decisions we are hoping to achieve during the meeting. Step 1. Establish proper setting. Choose a private, comfortable place and make sure everyone is seated. Remove distraction from the setting by turning off or silencing our pagers or other electronic devices. Make sure to sit at eye level of patient or family members. If the patient is incapacitated, determine which family members are going to attend the meeting in patient's presence or absence. Step 2. Make introductions and share intentions for the meeting. Team members should be introduced to the family or patient. Allow everyone to introduce themselves individually and try to know their relationship with the patient. Try to build relationship with them by asking non-medical questions about the patient, like what is the occupation of the patient. We can know the family dynamics. We can know how he is, his mental behavior or psychological behavior, and what are his hobbies, so that we can reduce the anxiety levels as we are new and the environment is new. And once we can make the comfort patient or family comfortable, we can delve into the problem further. One should note that the patient and or family will often assume that whenever a meeting is requested, it is because of an urgent decision that must be made, and it can cause stress and distress among the family, which will directly inhibit the communication. So, if there is no pressure to make an immediate decision, try to make this clear. Try to prevent anxiety and distress among the family, which may inhibit proper communication. Step 3. Assess patient or family understanding. Allow the family to speak first. It allows clinicians to assess the emotional readiness to hear difficult information or to make any decisions. Patient and family health literacy and the perspective of illness also will be assessed by allowing the family to speak first. Ask about the baseline function of the patient and any recent changes in case of any chronically ill patients. When traumatic events occur, like any trauma or traffic accident, the act of telling that story to an empathetic clinician helps the patient and family to accept what has occurred. gives time to let them sink, and it also improves the satisfaction with care provided. Ask the family about the concerns regarding their patient, what they're trying to achieve, or what they need for us to do regarding the patient. Open ended questions should be used to explore family's perception. Step 4. Give a concise medical review or summary in clear language. A clinician should summarize the entire picture in few sentences. He can add some recent events or the details that inform the decision at hand, what are the treatment provided, and what are the illness prognosis. And by repeating by events of the family or patient summary, events are placed in a context. Summarize the big picture in a few sentences. Use dying if appropriate if the patient is very clinically severely ill. Avoid medical jargon and use slow, even speech with frequent pauses to confirm understanding. If the medical term is introduced, inquire about family's understanding of the term. Medical terms like ventilation, intubation, or dialysis are unfamiliar and the patient cannot understand it. So, before introducing it, we have to inform them that the meaning of the word and whatever you're trying to achieve by providing those terms. Answer questions posed by patient or family and explain regarding the nature of care in ICU and the common procedures that are done in ICU. Step 5. Allow silence and response to emotion. Response to emotion is critical at every point in interaction. Failure to respond appropriately to emotions early in the interaction will limit the patient and family's trust in the clinician. Try to be empathetic. Dire news or bad news is often very difficult to accept by the family or patient, and the perception that the clinician does not care provides a reason to discount clinical opinions, and it also reduces the patient family's trust in the clinician. Clinician should not give too extensive medical information than necessary to the patient. Moments of silence often are vital to allow patient and families to process the information. Family members who have suddenly lost eye contact or physically withdrawn may indicate the need to pause. So we have to observe the family members while giving our diagnosis or prognosis. And if the family members are leaning back or looking away, they lost their eye contact or bowing the head or spacing out or crossing their arms, it means that they are lost in our translation, and we have to pause and allow time for them to understand what we are saying and allow time for them to sync for what is going on. There's a technique for responding to emotion which is summarized in the mnemonic NURSE. N stands for naming. Clinician needs to identify the type of emotion, like if it is the emotion is they are feeling fear or anxiety or anger. U stands for understanding. Once identifying the type of emotion, we have to maintain subtlety in understanding the situation and act accordingly. R stands for respecting. Resist the urge to make pacifying statements. I know you're angry or anything like that, or becoming angry, which and the clinicians emphasizing lack of control over irreversible illness to reduce guilt among family members. In case of grave prognosis, the family usually feels guilty and they feel guilty about the diagnosis. So we have the clinicians should emphasize the lack of control over the nature of disease and the irreversibility of the disease to reduce that such guilt among the family. Stands for supporting. Showing sadness when giving bad news with statement of emotion requires empathy and non-abandonment. E stands for empathizing. Acknowledge patients or families' hope and concerns. Step 6. Discuss prognosis. Key to prognostication include formulating prognosis based on medical facts and specialist inputs as and when needed. Inquiring how much detail the family desires, giving a range of possibilities like best case scenarios and worst case scenarios while acknowledging the uncertainty of prognosis helps in reassessing prognosis periodically with the family and patients and responding empathetically to emotions. Be clear and clarify the family about the prognosis and recovery to avoid confusion. Prognosticate about ICU discharge or hospital discharge in case of end-stage diseases. Try to know that prognosis and recovery are different in terms of family ideas. So, for example, a case of delirium is good prognosis for ICU discharge, but overall has a poor recovery. Step 7. Explore goals and priorities. Try to know what are the possible goals the family is trying to achieve, whether they're trying to achieve by prolonging the patient's life or improve the function of the patient, whether they want to take the patient comfort care or take him home to see a family milestone, or providing comfort care by relieving the suffering and staying in control. Step 8. Present broad care options. When the patient and family have finally fully understood the patient's current condition, explain them about the existing treatments and prognosis, it is possible to discuss the broad care options, whether they want to continue with the care or try to go for comfort care or end of life care. Explain them the best, worst, and most likely case scenarios. Express the priority of patient comfort no matter the goal they choose. Clinical team draws out patient or family perspective and helps in prioritizing goals. Involve the family or patient in decision making of the patient treatment. Step 9. Translate goals into care. Review current and planned intervention. Make recommendation to continue or stop based on the patient's clinical condition, prognosis, patient-centered goal. We can tell the family that like this is if the patient is having very poor prognosis, we can tell that the patient, maybe if he is present or if he is in this place, he may not accept to suffer so much, so you can choose that and lose your guilt. Try to discuss with the family regarding do not resuscitate conditions, hospice or home care, artificial nutrition or hydration in case if the patient is not able to take feeding enterally, and future hospitalizations. All summarize all decisions that are made. Respect the family or patient's wishes and respect their values regarding withholding of treatment in terminally ill or futile cases. In situation where prognosis is unclear or the family is requesting for time prolonging period treatment, using a time limited trial is both effective to build trust and treatment consequence. In time-limited trial, usually the clinician and the family discuss for a period of they're providing a period of time, limited amount of time, and give treatment, and will check for what if the patient is responding to treatment or like treatment, like if he's becoming, if unconscious patient, whether he's becoming conscious or not. And if the time is prolonged or the time is completed and there is no response, we prior to the start of trial itself, the clinician and the family members should come to a conclusion that if the patient if the we are not getting the accepted level of response, what should be done. If there are repeated requests for non-beneficial care, the team can consider and consulting a palliative care for assistance and to resolve the conflict. Closing the discussion with follow-up plan and ways to contact the care team reassures the family of ongoing support. Step 10. Document and debrief. Clinical documentation ensures patient safety and quality of care. A carefully crafted progress note documenting not only the time spent but also the level of preparation, the participants, context of options discussed, goals, and next steps provide vital information for members of the medical team. After the meeting, conduct a team debriefing among the team to ensure opportunity for teaching and reflection. We can learn from our mistakes, and during debriefing, we can say what all we can improve in the meeting or what went wrong with the meeting. Documentation provide a medical and legal record for quality of care provided. Breaking bad news. Bad news is defined as any information which adversely and seriously affect an individual's view of his or her future. This includes any ill prognosis or grave prognosis or diagnosis of any cancer or untreatable diseases. There is a protocol called Sprike's protocol, which includes S stands for setting, set up the conversation with the family or patient. P stands for perception, assess the patient's perception of the situation. I stands for invitation. Invite them to hear more about the diagnosis, prognosis, or the care options available. K stands for knowledge. Give them knowledge. E stands for emotion. Empathize with them on and create space for their emotions. Try to understand their emotions and act accordingly. S stands for summarizing. Summarize and strategize the care plans that should be done. Communication skills and training, teaching and analysis. As there are no proper training curriculum for communication in critical care, doctors tend to learn from their senior colleagues, which rarely challenges a trainee's idea of whether they are learning good communication or bad communication, or the difference between good or bad communication. The gold standard teaching tool is individual feedback or debriefing on videos of real meetings or simulation. For analysis, a classification of communication skills have been proposed by the Calgary Cambridge program. Three domains are used in communication. They include content skills, process skills, and perceptual skills. Content skills. It includes what is actually said, including the language we use and the information given. They are usually developed with practice because the technical aspects of critical care intervention, some doctors struggle to maintain balance with their level of knowledge and understanding and that of the knowledge of the anxious relative. Most of the skills should be simple while avoiding technical language. Try to speak with the family in simple, understandable language while providing pauses and using a language in which the patient or relative is understanding it. Process skills. It includes how a meeting is structured. Using techniques of signposting, agenda setting, summarizing, checking understanding, the efficiency and professionalism of consultation can be improved. These skills can be taught and integrated into clinical practice. Training during pre and post graduation levels can benefit those clinicians who have difficulty in communication, or it benefits the clinicians as a whole during training. There was a study conducted by Aspergen K et al. In 2005. The study is which basic communication skills in medicine are learned spontaneously and which need to be taught and trained. In this study, it was found that training during pre and post graduation levels benefited the clinicians in understanding the patients and helpful in communication. Perceptual skills. These skills include recognizing and dealing appropriately with feelings and emotions that arise during the course of a consultation. Such feelings occur on both the clinician, and family sides, and the first step to improve these skills is to be willing to understand the attitudes and values of the family by the doctor during a consultation for a better communication. A study by Fallowfield and colleagues found that perceptual skills can be improved with training. These are my references. Finally, to conclude, be sincere, be brief, be seated. Thank you.
Thank you. Thank you, Charishma. Madam, you want to add something?
Hi. First of all, I would like to thank Dr. Srinivas and Dr. Ghanshyam for having us on this platform today. I just want to say a couple of things. A good communication and proper documentation is very important aspect in ICU management of the patients, which also prevent us from having complaints, conflicts, and litigations. So, like, we should try and inculcate youngsters with the skill of communication in ICU by various methods, like including them in patient and family meetings, counselings, or debriefing and giving feedback of their own communication with the colleagues or families, or arranging training sessions. Such things can improve the communication skills. And I've seen in many parts of the world it has become, communication has become part of curriculum, and it's been assessed during their 360 degrees feedback and appraisal tools of everyone, of every clinician, staff, and all the people involved in patient care, which not only assess their clinical knowledge, ability to be a good team worker, and also assess their communication competencies. So I think maybe it's a good idea to start that kind of tool by our college as well in India to improve the clinical skill of everybody. Thank you, Dr.
Yeah.
Srinivas and Dr. Gansham.
Yeah. Ghanshyam?
Thank you, Charishma. Thank you, madam. Just a couple of points which I think is important. Whenever we talk about communication, we emphasize a lot on what we have to speak. Most of us are very poor listeners, and that is something that we need to be very mindful and develop the act of becoming a good listener. See, many a time when you're speaking to families, or for that matter, any other member of the team, if they have something to say, please give time and be patient in listening them completely. There's a difference between listening and hearing. Hearing is, just you are there. Listening is trying to understand what they're saying. And until and unless you try to develop that art, many a time what you speak also may not actually reflect with them. So be good listeners. Second, never ever speak to families in corridors, especially when you are dealing with critically ill sick patients. Try to avoid discussing or prognosticating patient's condition in the corridors. It gives a very bad impression. Many a time it gives an impression that you are not, you don't have enough time, or you are not very empathetic towards the patient's condition. Third, have clarity of mind of what you want to communicate, and don't be hesitant in using words if you want to you want to convey whatever is there in your mind. For example, if you have a patient who is very sick and the probability of him dying is very high, don't hesitate to use the word that the patient is likely to die or may die. Many of us try to avoid using such words, and thinking that it may look insensitive, but that is something which is very needed, because patient's family should also get time to adjust to the fact that their loved ones may die. So do not hesitate to use those kind of words. But again, you have to be a little sensitive when you're using that kind of words. Uh, Fourth, choose what methods of communication you want to use. As Charishma said, there are multiple ways of communicating: visual, audio, multiple ways. So I always prefer to have a pen and paper where I sit and jot down whatever discussions happen, so that the family also is very clear about what we have discussed. And fifth, be very, very clear about who is communicating. Just to give you a very, give you an example. This happened just a couple of days back. We had a sick patient, smoker, severe vascular disease, came with non-healing ulcers. The plan in the team was that he might end up with amputation. Now, this was a discussion which happened only among the team members, right? Which was not yet completely formalized or not yet conveyed to the family. The resident, who also happened to be there while the team discussion was happening, inadvertently during the evening routes told the family that we are going to amputate. And the next day, there was such a huge conflict between the family and the treating team that we had to spend at least a couple of hours trying to get things sorted out. So please be very clear about who is speaking and whether the point of conveying whatever has to be spoken, is that being confirmed and agreed upon by the entire team. That's very important. And lastly, within the team, we generally again focus about communication only with the families or the patients, but it's very important that in a team like intensive care unit, you need to be very clear about what you want to communicate to your colleagues, to your juniors, to the nurses, to the paramedicals, as well as the administration. So there has to be a clarity of thought, and there has to be a clarity of this communication being passed upon among all the team members. Thank you.
Yeah. Thank you, Sean. Thank you, man. I think communication, first point is both verbal and non-verbal. So what we do non-verbally has a greater impact on our ability to build a rapport with the patient than verbal communication. Most of the mistakes we do is, as Ghanshyam said, we'll try to counsel in a corridor or standing in the outside the ICU. That should not be the way we should do it. Patient's family should be sat down in a comfortable environment, introduce yourself, inquire their well-being, their state of mind. Always keep your phone away from you. Maintain eye contact with the family, and keep them updated about what's happening in the. And sometimes you are speaking to them after a night shift where you don't know what happened to the patient. So keep yourself updated before you speak to them. That is the clinical aspect. But most importantly, giving comfort to them, sitting with them down, understanding their psychology, their frame of mind at that point of them, have they had breakfast or not, have they had a coffee in the morning or not. You should be able to get that empathy, show that empathy to the concerned family. And the other mistake we do is being in the profession. We become insensitive to what we are talking with other colleagues in the lifts and in the canteen or in the parking areas or whatever. You don't know who is listening to you. So do not discuss about patients' condition or the approach or the attitude or the prognosis anywhere outside the realm of the ICU and in the counseling room. You don't know who is hearing what. The other mistake we do is we believe that communication is within the team, communication is between the critical care team and other specialties, communication is between the doctor and the family. What we forget is that we need to communicate with the patient. If you see elderly patients who are in the ICU, they are very concerned about what's going to happen to them. They're very concerned which of their relatives are actually visiting them. They're actually concerned about what future treatments are. And we believe that because they're elderly, we should not discuss, because they're sick, we should not discuss their channel of communication open with the patient as well. That is the crux of all this. Why are we having this talk about communication in the ICU? It is to improve the quality of care with the patient in this. So the patient has to be the focus of communication, and never make fun of somebody's agitated behavior or somebody's bad talk in the ICU in front of the patients. And whatever we may think, patient may survive, may not survive. I don't think we should talk about it, even if the patient is sedated. I was on ventilator myself with a head injury, and they had said paralyzed me without sedation. I could hear what was going on, and the talk that was going on was young guy, rash driving, he's going to die. And because of their lack of sedation, my blood pressure had shot up. They thought that my brain intracranial pressure was rising and I will cone soon and I will die. And I could hear that. Now that's the worst thing which you can do to a patient who is partially conscious, who is listening to what's going on. And this is not something, it's an isolated incident. Patients who come back to us for follow-up after 1 year, after 1.5 years after discharge from the ICU, can actually recollect voices. They don't recollect faces, but they can actually recollect voices and tell who spoke what during their sick phase in the ICU. So communication is an all-encompassing aspect, and as has been mentioned, it is given very least attention in training programs, and that is where most conflicts arise between families and patient. But it was an excellent presentation. I think it was a very good capture, a snapshot of what communication in ICU means. Thank you very much, Charisma. Excellent work. Thank you. Next week, we will start our series of multi-organ syndromes. We will talk about hepatorenal syndrome, and then we'll go with the other syndrome. You want to say anything, Charisma? Charisma, you want to say something?
Thank you for giving me this opportunity, sir. Thank you very much, sir. I thank Hicks Community, Srinivas sir, Gansham sir, and Rani ma'am for giving this opportunity, sir.
Thank you.
This will be a continuous activity tomorrow after your exam.
Srinivas, I think we are losing you.
You will face us again. We'll come back. Have a good day. Join us again next week. If you have any step which you also for the next 9th edition of Hicks on the 10th of May, 11th of May, 12th of May, and our book on the best articles of 2023 has just been released. If you are interested, you can buy it online. Thank you very much. Join us again. And